We now want to think about a tension pneumothorax. Now, just as with a simple pneumothorax, there's still air in the pleural cavity, but this time there's some sort of flap that acts as a valve. And this means that air can get into the pleural space, but it can't get out again. So more and more air progressively collects in the pleural space and fills the pleural space up. As the pleural space fills completely under pressure, the affected lung is going to completely collapse. It's going to go right down to a fairly small volume. But as well as that, if there's a tension effect, there can be pressure on the heart and the major blood vessels in the middle of the chest. So as the pressure here builds up and up and up, it's going to press on the vessels and the heart in the mediastinum. The mediastinum is this area in the middle of the chest with the heart and the large blood vessels. So there can be mediastinal shift. So let's think about that with the aid of a diagram. So we've got a chest wall that we're familiar with the diaphragm. And as we know, there's going to be lung fields. Right lung. And the left lung is going to contain an area here, round about there, containing the heart. And that's the rest of the left lung. But importantly, we've got the large vessels associated with the heart, the superior and the inferior vena cava, and the aorta is going to leave there, and there's going to be the pulmonary artery. So we've got the large vessels in the chest as well. So if one lung collapses, let's suppose this lung collapses, and this lung becomes very small and collapsed. So this is now a collapsed lung because all of this area has become a pneumothorax. And the pressure here is increasing because air can get in, but the air can't get out. So we've got a tension pressurised pneumothorax. I think you can see here that's going to press on the mediastinum and the contents of the mediastinum and push it across that way. So there's going to be deviation in that direction as the pressure increases. And as the pressure increases, it's going to tend to move the major blood vessels, and especially the veins where there's not a high pressure inside, the pressure can close off the major veins. And as well as that, the major veins are going to be pushed across and there can be a kinking effect. I just want to demonstrate that with this tube here. As the pressure pushes across, then this tube is going to be pushed, and this tube's a vein, remember, and you can see there's going to be a kinking effect in the vein. Now there's a kinking effect in the vena cava. That's going to reduce the venous return. There's going to be reduced venous return to the right atrium. The blood's not getting back to the heart. So there's going to be reduced venous return to the heart. And if there's reduced venous return to the right side of the heart, there's going to be a reduced amount of blood going out the pulmonary artery to the lungs. That means there's a reduced amount of blood coming back from the lungs in the pulmonary vein to the left side of the heart. So there's going to be an acute reduction in cardiac output. In other words, the patient's going to become shocked. So the patient's going to have respiratory problems and circulatory problems as well. So how are we going to recognise this? Well, there's going to be respiratory distress. The patient's not going to feel very good. They're going to have difficulty breathing, and there's going to be air hunger. And as well as that, the trachea can be deviated. Now, the trachea should be central. So in a trauma situation, we should always palpate for centrality of the trachea. Because if there's a pressure effect on one side, that's going to push the trachea over, and the larynx is going to be pushed over as well if we feel that. So if there's a tension effect on this side, the trachea is going to be deviated away from the side with the tension in it. Or if the tension was on the left side, then the trachea will be deviated away from that. And as well as that, if we listen, imagine the tension pneumothorax is on this side. If we listen, because the lung is all filled up with stagnant air, in the pleural space, we're not going to hear the breath sounds. So there's going to be absent breath sounds, and because in a tension pneumothorax the lung collapses completely, there's going to be complete absence of breath sounds on the affected side. And then when we percuss, when we tap, again all over, because the lung is completely collapsed, there's going to be hyperresonance all over the affected side. So there's going to be these respiratory effects. And because there's a reduced amount of blood going back to the heart, there's a reduced cardiac output, there's going to be an acute hypotension. That's going to trigger the sympathetic reflexes in the medulla oblongata, and there's going to be tachycardia. So there'll be a tachycardia with a hypotension at the same time, because there's no blood getting back to pump out. It's going to be compressed. It's this tension effect. And sometimes, if you look, there's going to be distended neck veins as well. So if there's increased pressure in the chest on this side, the blood's not going to be able to drain back in, and you may or may not notice the distended neck veins on the affected side. Of course, if the patient's hypovolemic as well, that's going to be that much harder to detect. Let's just look at this on the model here. So here we have the mediastinum with the heart. Here we see the superior vena cava. Here we see the aorta. This vessel here is the main pulmonary trunk. That is the main branch of the pulmonary artery. And just behind here it divides to go to the left and to the right lung. So if there's a pneumothorax on this side with a tension effect, then that's going to tend to, imagine this tube now as the vena cava, that's going to push that over, and I think you can see it's going to compress the vena cava. It's going to compress the major vessels, as well as compressing the heart itself, of course. So not only do we have a respiratory distress situation, we also have an acute obstructive shock situation. This makes this condition clearly an immediate life-threatening problem that needs to be addressed fairly quickly. In fact, immediately. The patient is in immediate danger. So this is a clinical diagnosis. We don't have time to wait for radiographic confirmation of the diagnosis. We need to diagnose it clinically. We can't delay on this. So what do we need to do? Well, in the emergency situation, let's go to the skeleton now. Let's imagine the pneumothorax is on the left side of the skeleton, in the lung in here. What we need to do is get the pressure out of here so that the heart is no longer being pushed across, to get rid of this mediastinal shift. Now, the patient can survive on the right lung for a fair old period of time, but they can't survive with a compressed mediastinum. So what we need to do in this situation is decompress the pneumothorax. And we do this in the second intercostal space, in the mid-clavicular line. And it's just a question of putting a cannula through into that, preferably a large bore cannula, taking the metal bit out, and then if you made the right diagnosis, it will go psss as the air comes out. And the patient should get some relief from that instantly, because what you've done in that situation is converted a tension pneumothorax into an open pneumothorax. And that buys you a bit of time. But the definitive treatment, like any pneumothorax, is use of a chest drain with an underwater seal. So the chest drain might go in the fifth intercostal space, 1, 2, 3, 4, 5, just anterior to the mid-axillary line. And then, of course, we'll connect that up to our good old underwater seal drain that's going to let the air out, but not let the air back in. It's going to form a seal. So 1, 2, 3, 4, 5. So that would be connected to that, and we'd sew that in and make sure everything was nicely airtight. This is going to let the air out without letting the air back in, allowing the lung to re-expand. We can then pay attention to the initial injury, which may heal itself, or that gives us plenty of time to get a specialised surgical opinion in to repair the initial injury. So that's the basic thinking of a tension pneumothorax and how we would manage it. So remember, it's a clinical diagnosis. There's no time for chest x-rays. So we're looking for respiratory distress, tracheal deviation, absent breath sounds on the affected side, hyperresonance on the affected side, tachycardia, hypotension, and possible neck vein distension. Now, as well as getting air in the pleural space, it's possible to get blood in the pleural space, and this would be called a hemothorax. And we want to think about a hemothorax next.